Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast, I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces that are designed for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com for your shoulder brace requirements. We've also just expanded now to the UK, so if you live in the UK or Europe, you can get your shoulder braces much more quickly. So check us out at flawlessmotion.co.uk and you can check out our shoulder braces there. Cheers. Hi everyone, welcome to Glenohumeral Gurus, and today is my great pleasure to welcome Kathryn Fahey to the Glenohumeral Gurus podcast. Kathryn, welcome. I'm really looking forward to connecting with you and sharing your story with everybody. It's nice to have you on board.
Hey, awesome to be here, and really nice to finally get to have some words with you. And we've been passing a lot now. Hopefully, this is the start of something great.
Exactly. And I think that's what I'm really enjoying about these podcasts is I randomly message people that I want to connect with. And here we are. So this is wonderful. Can you tell people about your physio career so far, what you've been up to and what you're currently doing?
Yeah, so I think my career in physio started quite early as an athlete, and 20 years ago going in for a slap repair. After I would say failing physio after 2 weeks. I love that word, failing physio after 2 weeks. And then yeah, so I was that cohort that had like a 12-week immobilization, and I always remember coming out of the sling and looking at my arm and just completely emancipated from a muscle loss point of view. And I think that's where my interest probably started quite early. Took a little bit of a leap of faith, and I did the Bachelor of Science in Athletic Therapy and Training in Ireland, which was a relatively new degree. I think I was only the second year. And I kind of took a chance on it because I knew kind of physio is what I was interested in, but I knew I was kind of more maybe biomechanically kind of analysis detective. I kind of enjoyed that side of it.
Yeah.
So did that as my degree in DCU, and worked for a little while and went on to do my master's in UL in physiotherapy. And I was really fortunate to meet Karen McCreesh and did a project on the band sizer, so looking at
Oh,
exercise
yeah.
prescription. And yeah, it was really interesting just looking at, what our prescribed load was versus what we actually what the patients actually achieved. And yeah, all the time kind of working clinically. I literally was the founder of Elite Performance Physiotherapy, so director of a clinic in UL. I was really fortunate to work in a campus, a high performance sporting campus. And so fortunate to work across so many different sports, which is really
Mm.
nice, from Gaelic games to our high performance swimming. So I started working with high performance swimmers, athletics, which I absolutely loved, and a little bit of academia, which probably was the reason why then I felt okay, clinically I was seeing a lot of patients that were post-op, and I kind of always asked the question, did you try physio first? And kind of really didn't. And that was kind of the question around, I've seen a lot of post-op shoulders, but none of them had really trialed any sort of conservative management initially. So kind of luckily enough, spoke with Karen, and that's kind of where the PhD started back in 2019,
Yeah.
looking at large to massive rotator cuff tears, and really looking at seeing, was a conservative approach, um, a doable one, really, I suppose.
Mm-hmm.
What were the questions around it? And to be honest, I would always say I'm a clinician with some questions.
Yeah.
And just, expose myself to learn through academia and through a PhD. And I think that's what a PhD is about. It's about learning.
Mm-hmm.
It's about learning how to answer questions. And then finished my PhD and graduated and took a little leap of faith and moved from lovely cold Ireland, green but cold Ireland, to the desert and started in Hospital Orthopedic Hospital in January of this year. Um, and look, a really exciting journey for me and kind of placing myself maybe in the best place from a point of view of, still working clinically, which is really important to me, but, been surrounded by some really great people with
Mm.
great minds and probably all looking in the same direction of trying to improve patient care. And yeah, so 11 months later, today,
Yeah.
11 months later,
Wow.
I am still in the desert.
Yeah. We were in Ireland recently. I've never been to Espartal, but it is dry and hot. Is that?
Right now it's absolutely gorgeous. I would say everybody kept talking about the summer, the summer, the summer. And I'm going to be honest, like probably maybe the second week into July, into August, it was a bit unbearable, but I went home to
Yeah.
Ireland in that time. So that is the very nice thing. I don't think I remember having a month off in a very long time. So we tend to block our time off. But no, right now, absolutely perfect temperatures, mid 20s,
Yeah.
really, really nice. Days
Right.
are short. It's the only thing I cannot get used to. In the summer and in the winter, the days are short. So by 5 o'clock or
Okay.
6 o'clock in the summer, it's dark. And that's
Yeah.
the
Right.
only thing I have to complain about.
Yeah.
But
Yeah.
no, I'm not your typical Irish. I'm I'm very much a fan of the weather and the heat, and as an athlete, I think as well, it's an amazing place to
For
train and
training. Yes.
yeah, so it's
Yes.
really nice.
So there's lots of things from that story that tell me what you know about the band sizer and how that works and whether yeah, tell me about that project with the band sizer that you did.
Yeah, it was
Or
really
what it
interesting.
is for people who don't understand what it
Yeah.
is.
So the band sizer is this, it was just a little magnetic device, and you'd put it onto the TheraBand. And it was kind of twofold. So it measured obviously the time under tension, so the TUT. So it measured the time under tension, but also it was a feedback tool. So
Mm,
it was twofold. So for the patient,
yeah.
essentially, if I set it to a concentric action of 4 seconds, an isometric of 2 seconds, and an eccentric of 4 seconds. So you're looking at a 10-second load for
Mm,
one exercise or for one repetition. And if you give them 20 repetitions, depending on what you're giving them, essentially you're looking at 200 seconds of time under tension, which is your
yeah.
full allocated load. And
Yeah.
then actually so was, we gave them the 10 or the 20 exercises. I think on average, I think around 40% was the execution because we used it both with the app and without the app. So we are kind of
Mhm.
they were doing the reps, but the time under tension wasn't matching what we were prescribing. So
Why is that?
automatically, because if you tell somebody, okay, I want you to do, 4 seconds out, hold it for 2 seconds and 4 seconds in. And if you verbally tell them and you show them what to do and they
Yes.
go home and they do it,
Yes.
it would never look
Then.
like
Yeah, okay. Yeah, one, two, three,
that.
four. Yeah.
Yeah, so
Really
and we
fast.
did it with both. We, gave them 2 weeks of the exercise without the app, and then we
Yes.
gave them 2 weeks with the exercise with the app, and it was really nice because if you're looking at especially tendon and Karen, that was Karen's kind of PhD around tendon load, and if you're trying to,
Yes.
increase load or monitor load and progressively overload, yeah, you're prescribing them the sets and the reps, and you're presuming that they're doing it according to your timing and your time under
Yes.
tension. But actually, I think 40% was the execution
Yeah,
percentage.
wow. And did
Really
that
fun.
change with the app? Did you
Yeah,
see? Yeah.
because
So they get the
they had a
feedback.
bar that they
Yeah.
could follow and hold, and then it would go red if they went outside, or if they went too quick, or if they went
Yes.
too slow.
Yes.
Um, so you know what? It was a really nice device.
Yeah.
I actually don't know what happened to the company or whether it was something that still it was Scandinavian, so I don't know
Yes.
whether they
Yes. I've just been looking around the band sizer in the last few months. So I was interested to hear. I hadn't heard of that project. So
Yeah, it was so good. It was so
yeah.
good. And again, I think for me, it's always like attention to detail is my big stickler. Like I just
Yeah.
really like attention to detail, understanding the exercise, executing the exercise. And I think
Yeah.
sometimes we don't quantify that enough to know, oh, the exercise didn't work because it
Yeah.
didn't work. Or is it just that we didn't execute the
Yeah.
exercise?
And then I see clinicians jump quickly to something else and something else and something else, but always looking for perhaps a new exercise without really appreciating the detail and the execution, like you say. So
So yeah, it's really nice. That was kind of my first real kind of, I suppose, dive into research and understanding it. And I guess I had a really positive kind of experience with
mm,
how it really could improve care. And I
yes.
think, 2018, and then went back teaching for a year, working clinically. And then I was like, no, I still have more questions. Let's go again. Let's do a PhD, which didn't feel like a PhD. I won't lie. It really didn't. As I said, I felt like I was just trying to answer some
But
questions.
I think that I would agree, and that for me, I felt like the PhD is like learning how to research. You learn so many principles, and my question was then really great because I'm supported by some really excellent academics that could actually help me learn. So it's such a nice thing for people to do. I think so. It's
And I think for me, it's like for clinicians to take away from, like, you have people like yourself and Adele and, immersed in, shoulder, immersed in research, immersed in clinically trying to figure out. And we still have to ask other people questions because we still
yeah,
don't know. That's
yeah.
really important because, and that's where I see it. Like, I'm very fortunate in Aspeter. We've got a shoulder specialization group, and like there's across, because we've got four different physio departments. It's really, really
Mm,
big. And
mm,
like we probably have 10 really good shoulder physios. We've got two
mm.
shoulder surgeons. We've got a dedicated person now in our biomechanics lab doing a PhD on shoulders. Like, and that's all of us trying to figure out what's going on.
Yeah, yeah.
So
And I think
there's
it's great when you can share ideas and realize what you know and what you don't know, because otherwise, I mean, yeah, for me, I think I end up thinking that my way is the only way because you don't get that same exposure, and then you're like, oh yeah, I could do it that way. Like what if we did it this way? What if we did it like that? So I think that's where the evolution is great, and
that's
yeah, I guess.
that's the goal.
Yeah, technology is really helping us in this space. Tell us about your PhD then. I know you've published some systematic reviews on large,
Yeah.
massive rotator cuff tears. Tell us what you know about that.
I think my first school when I started the systematic review, I remember saying this to Rose, and I was like, I do not want to be one of those people that does a systematic review to say, we don't have enough research, we need to do more research. I was like, that is not me. I am telling you now. And that was my biggest thing. I was like, right, I need to have a question and I want to be able to, formulate something from it.
Yeah.
So yeah, so we did a systematic review, and really our question was like looking at the kind of large to massive cuff tears. So really large to massive cuff, you could define it really as kind of two tendons,
Yes.
which again is hard to define because a lot of the times we know at that footprint it can be super and infra at the same time, and you look at kind of maybe around 5 centimeters. And again, depending on who's reporting on your report, depends whether that's an AP or a longitude. So like already now I question so much because I know so much more. And like the biggest thing was when I looked at the research looking at surgery or conservative management. And conservative management, we looked at kind of exercise intervention based stuff. Was that I think 14% of the patient cohort in the systematic review met the criteria.
Yeah.
This was a big issue. So you've got information from a systematic review where literally, as I said, like some papers had 4%. So if
Mm,
you've got such a mix, a
mm,
heterogeneous population, but yet you're trying to collate and come up with an answer to
yes.
say it's effective or it's not effective. Like for me, it was like taking knee injuries because
Yeah.
they are so different. So that was the biggest thing that really was, if we are doing research, we need to get better from a point of view of describing the population and describing the cuff tears. So that was probably the biggest thing for us initially. You talk about, and I know there's a lot of research at the moment as well. I think it was Hansford, and it was like, how much is good enough?
Yeah.
So when you talk about, yeah, well, pain was 0.5 on the VAS better, I think, at 12 months for the surgical group versus the exercise group. But like clinically meaningful, you
Mm.
know,
Mm.
or didn't cross over into any of the qualitative quality of life, or
Yeah.
um yet we saw actually range was a little bit better in the exercise group versus the surgical group, but yet that didn't cross over into improvements in quality of life. So that was kind of the biggest thing, was like really getting to understand data, and really
Yeah.
understand that the pool was so mixed.
Yes.
Probably the second biggest thing, for probably more for me as a physio, was like, so that was the first part. And the second part, we tried to pull, kind of similar to what Sherpa did, we tried to pull the information from the interventions.
Mm-hmm.
We used the CERT. I don't know if you've ever seen the CERT, and
No.
I think it should be mandatory for physios doing research to describe their intervention. So it's a consensus on exercise. It's a template that looks at different parameters of your exercise, and you need to be able to describe, supervised, unsupervised, and
Yes.
you get points. The same thing.
Yeah.
You could not, you could not collate, and you could not come up with an exercise intervention, because the majority, I think, out of the average of maybe a score of 20, I think 7 was nearly the average score on how many
Yeah.
points people actually had um described their exercise based on. And like one of the biggest ones was like patient satisfaction, which we know is a really, really important prognostic factor. So like for me, it was a real eye opener, to like, yeah, we have research that's trying to help us formulate decisions, and that research is really poor,
But
really
it's
poor.
actually also a really good message to clinicians too, isn't it? Who are reading the research and thinking, oh, I should be doing it like that, without necessarily appreciating that, oh, they've missed this, or what did they do about that? You know?
Yeah.
Did you contact the authors there to see if you could get more info?
Yeah, yeah, we did. Oh, and because like sometimes they didn't have the exercise intervention on the paper, so I needed to
Yeah, right.
contact them information, like, and this is the problem, like, it's documenting what you're doing. Like, how can we start to collate information and try and decipher what is a better
Mm.
option, until we all
Mm.
start, maybe looking, or just having the same information,
Yeah.
and
Do
that's
you
why the
think that
template.
is it a word count issue? So something obviously people is it so when you contacted the authors, did they have that information or they didn't know? They
Yeah,
hadn't.
one we had gotten back, yeah, and then two we hadn't. And like, I don't, I get what you're saying from a word count. No, you could put it as a table. The cert,
Yeah, okay.
like, it's really simple table. It's really
I,
simple. It's a really nice table. I actually I would recommend you to have a look at it. The cert,
okay.
and it's so nice because like it really does have some really good parameters around adherence,
Yeah.
supervised versus unsupervised, group based versus like, so it's really, really nice to kind of explore the things that possibly might be influencing the outcome, rather than
Yeah.
just look at our pain, our strength.
Yeah, yeah.
Uh, so like that was massive. And again, it was massive. I felt it had a bit of impact for me because I am the physio, and I want to be like, oh, do you know what? They're right there, because you do this and you're not really sure, and you're not writing it down, or
Yeah.
you don't think you have any. And it's like anything else, because we don't know. We need to just try and record everything.
Yeah. At least this way, I've just made a note, so I will find the template and
Yeah.
put it on for people to have a look at. They can download from the podcast and then really think about how they quantify their interventions, and what they're missing and what they're not missing.
Yeah, exactly. Like, and like if you, I think I summarized it quite well in the systematic review actually, and just showed
Yeah.
the table. Like, it's actually
Okay.
kind of going, oh my
Okay.
God, how did you even say
And then
whether it was
you went on to do a qualitative study, you were saying. Tell me
Yeah.
about that.
Yeah, so I think, and again, it came from being the clinician, definitely. I think I started the PhD. My goal with the PhD was, can I design an exercise intervention and pilot it, or maybe have a feasibility study. I knew from a time perspective, I was not going to be able to do an
Yeah.
RCT, and I was realistic around that. So my initial goal is exercise effective or not in managing this cohort, have a look at the research, gather some information,
Yes.
and then design an intervention. And in between that, I had a kind of conversation with Karen and a conversation with Rose and Jeremy. And I was like, you know what? Like, for me as a clinician, the patients are really important, because I feel we don't listen to them enough.
Yes.
Then I feel like we don't educate them enough to get the right information back from them. So at that point then, and Rose has done some unbelievable work in qualitative analysis.
Mm.
So that was the next step where we looked at um, interviewing patients that were either surgical candidates, non-surgical candidates, post-surgical repair. So we just wanted a full spectrum.
Mm.
They did fit in the large to massive, and I was very strict on that. So they did fit in the large to massive. Really nice cohort at home because we've lots, probably similar to you guys, we've lots of farmers, you know.
Hmm.
So I went down West Limerick and
Yes.
went up to the Midlands. So I kind of just spread across as well, just to get a kind of an idea. And did a really nice qualitative piece. And like the heading of the paper was like, if you thought I was going to go and hurt myself, you had another
Yeah.
thing coming. And it
Yeah.
was one of the patients talking about the exercise that the physio had given him that was hurting him, you know? And it kind of changed the direction of my PhD because it was astounding how poorly managed this cohort was. Like,
Yeah.
really poorly managed, sitting on waiting lists, waiting for surgical opinions, even though they were never even going to be a surgical candidate because they were probably,
Mm.
68, 70.
Mm.
Or the biggest one was, I don't know why I'm going to see the surgeon because I don't want surgery.
Yeah.
Um, so a big piece around kind of education, understanding confidence. Confidence was a really big one that came across a lot. And it was both directions. So it was confidence for the patient in the clinician, which was
Mm.
really big, but also the confidence of the clinician. And at home, our GPs, probably the same with you guys, maybe. And again, the guys in Canada have done unbelievable work on this as well. So the GPs are often the first contact point. We don't have the first contact point physios yet. We're kind of working on
Okay.
that.
Yeah.
We're not very good at that. They go to their GPs. Typical at home, Mary will go down the road and see her local GP. And the GPs weren't confident. So the
Okay.
qualitative piece looked at the patients, and
Yeah.
then I picked GPs, surgeons, physios. So a really nice cohort. So we had 12 and 12, um, interviewed independently, and astounding. It was probably the word I would use with some of the information that came back. And like, then I was like, right, I have a job here now. I have a job to try my best to fill some holes here and fill some gaps,
Yeah.
and help educate our clinicians and our GPs and build confidence,
Mm-hmm.
um, make better decisions because we
Yeah.
weren't,
Yeah.
and then instill confidence in the patients to know that actually this clinician knows what they're talking about, and I'm happy to wait and
Yeah.
go with the process because we know it's not 2 weeks or 4 weeks or 6 weeks.
No.
It's your 3 months or your 6 months, and I think they lose the confidence when the the progression is as quick as because they
Isn't
don't
is
expect it,
slow.
they don't
Yeah.
know. So that was that big piece. And you know what? It
Yeah.
was wonderful. I loved it. I
Yeah.
absolutely loved it. It
It's
was
such an
really, really,
important piece though, isn't it? Because like you say, we have these assumptions about what's happening, but actually until you listen to people and hear their experience, you don't know.
yeah. I think the biggest thing I learned is, and it comes from college, you learn your objective assessment, and we probably don't spend enough time on subjective, and that's definitely been a big shift for me.
Hmm.
Um, and the second thing is we often collect data and calculate what we think is important.
Yes.
What's important to measure here,
Yeah.
range or, yeah, I think we're moving. I do think we're improving on that. But like, I think back 5 years ago where you fall into that, they come in and we check range and we check pain, and we're always checking things that are like objective and measurable. And
Yeah.
yes, there's an element that is important, but like, my first question, they come in and like, how are you feeling?
Yeah.
Like, were you able to put out the washing today? Like, I mean, that's where it needs to go a little bit with this cohort. And
Mm.
I think understanding what's important to them, that was a big thing. Like, he's a farmer and it's calving season, and he's going to be in trouble, and you're giving him techniques to mind himself, or
Yes.
I think that was a learning process. So it's not just about what I think is important that I need to collect as a clinician.
Yes.
It's
Yes.
really, what do they need to do and what's important to them.
Yeah, it's a great reminder, isn't it? And a great piece to bring into the research because then it helps clinicians. I think because people who don't do research know that anyway, but the disconnect between what is being published and what is actually maybe useful to the patients as the end consumer. It's a
Yeah.
really
And
nice reminder. And then, so that leads us then into the karma cuff. Tell me about that. I don't know much about that.
I think sometimes we're always looking forward, aren't we? And every now and then when I do something like this, or I'm doing a presentation for something, and I pull up the camera cuff and I look at it and I'm like, I'm actually really proud of this, you know.
Yay.
And it's so nice because, as I said, at that point, my PhD just changed slightly.
Yeah.
So, yes, I wanted an exercise intervention, but for me, that was the end point of the patient care, like the patient first contact with GP or whoever it might be, and then they roll through this process. And really, I was like, why am I designing something at the end when they're not even getting to the end? Or, the path in which they're going through is suboptimal care. It's,
Yes.
it's not enough. There's time delays. These patients are getting worse because they're sitting on waiting lists or they're not reading, they're not getting to the right time point or the right care, within.
Yeah.
Essentially, I designed a pathway and like I also, one of the questions someone asked me, what's the difference between a pathway and an algorithm? And I don't know the answer massively, but I knew in my head I didn't want, and I know Best have done some brilliant, really
Yeah.
nice infographics to help
Yeah.
help clinicians make better decisions. But I knew in my head I didn't want this like tree of like, neck pain. No, we'll move right. Shoulder pain, yes, we'll move left. I just knew that wasn't what I wanted. So what I built
Because
was
why? Why didn't you want that?
because I don't think it's that easy. I think
Yeah.
like there's so many other variables that like, that influence. So when you look at the calmer cuff, you still have a flow chart. You still have a
Yeah.
path and a flow
Yeah.
from your subjective into your objective and then dividing off whether it's a surgical or non-surgical. But
Yes.
what I put was pillars. And for me, the pillars were vital. And one pillar on the right was a call to action checklist
Yeah.
for clinicians. And the pillar on the left was what do patients expect from their care?
Yeah. Okay.
And for me, yes, I think we're good. I think we're good at like, okay, so, they have active flexion past 90. They don't have an external rotation leg syndrome, or they don't have a massive deficit in strength on resisted external rotation. Active is equal to passive or vice versa,
Yes.
whatever it might be. I
Yes.
think, and I really simplified the points because again, this could be a GP, not a physio.
Yes. Yes.
So I really simplified, and this was through a co-design process now again. Patients,
Yes.
healthcare practitioners, round one. I collated it, came up with essentially a thing, and then we brought them together, which was so nice, having the patients and the
Yeah.
healthcare's in the same room. And I wanted to separate at the start because I didn't want what they wanted to be influenced by the doctor sitting over there, the surgeon
Yes.
sitting over um, and it was so refreshing because for me, we talk about patient care and it's important to include the patient. I was the complete opposite. I was like, the patient is the center, and
Yeah.
how do we build this around them? And how do we ensure that they get the right care at the right time within the right time?
Yeah.
Um, and like again, I look at it now and I'm like, yeah, but acute on chronic could go that way. And this is the thing. It's like it's there to help, it's there to inform, it's not the black and white. I think sometimes we look for that box, we look for that
Mm-hmm.
kind of fit in there.
Yes.
A lot of discussion around injections. When do we do them? When's the right time to do them? Should we do them at all? And then I still really wanted the exercise component because that was really important to me.
Yes.
um and I was like, at least give me that. So we did. And like I went over to Karen in Australia, Karen Jin, and
Yes.
like, obviously based around some of the EMG studies. And again, coming back to what we said there a while ago, I think sometimes as physios we go, okay, given that exercise, oh, it doesn't work, we move on.
Mm.
And I'm like, well, first of all, what are you assessing to figure out what you need? What are you giving them? And are you targeting what you think you need? And then retest it and see, has it worked? So I
Mm.
tried to keep it really simple. So really just use some of the really simple isolated glenohumeral rotation into external rotation,
Mhm.
internal rotation, depending on whether they had pain through flexion or pain through abduction. That was it. But I was like, if we can get them moving, educate them around, the pain and all that, So I had the nice little box at the end, and like it was 12 weeks, make sure we all know, like, and educate them around the time frame. And then like also like there's always a plan B. Always a plan B. So having the loop back around to go, okay, we've trialed conservative, the patient expectation isn't been met, don't be afraid to talk to the surgeon. And I think as well, I think as physios, it's really important we do have those relationships. I was so fortunate, like at Ruth Delaney in Dublin, Tristan Cassidy in Limerick, like two unbelievable surgeons that I could ring and go, look, I have a patient here and I really am not sure. And it's like, that's what it needs to look like, I think. And yeah, I designed, we got a really nice graphic designer, and the infograph looks really, really nice. And there's like QR codes, so you can give it to the patient so the patient can watch the video. And I used a patient of my own to do the video. He was a 76-year-old, had a puffed hair, and like it was just real to me. And that was kind of like, okay, this is what it needs to look like. And yeah, like it's been really well received, which has been really nice. And
they're super
yeah,
great.
we'd like to pilot it and see, obviously, is it working in clinical practice? But then I left the country.
Yes. Okay. Yes. And so because I want to hear about what you're up to now, but I will put those links then in the podcast as well for people to get hold of and take a look at that as well. So that was part one of our session with Kathryn Fahey, where we talked about the rotator cuff. So join us now for part two, where we dig into what she's doing in Aspetar and some of her return to sport testing. And thanks again to Flawless Motion for supporting this episode. So if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.